Medications for opioid use disorders in correctional settings. Shifting the paradigm, creating a balanced correctional and rehabilitative approach. The Opioid Response Network is funded by SAMHSA to provide resources and technical assistance needed locally to address the opioid crisis. This video is part of a series to provide guidance on the implementation of medications for opioid use disorder in correctional facilities. Leading corrections and behavioral health experts present information on topics such as the use of medication, models of delivery, diversion, and linkages to care and community support. Ed Hayes and Michael White discuss linkages to care.
My name is Ed Hayes. I'm an assistant superintendent with the Franklin County Sheriff's Office, which is located in rural western Massachusetts. We do have a rural county in Massachusetts, believe it or not. I'm the treatment director there. And I work with Dr. Ruth Poteet, who's our medical director. So Franklin County, yeah, it's small, rural, about 70,000 people. Our jail is small for our Massachusetts jail. We're talking maybe our count now is more like 180. We're federally designated as rural. We have half sentenced, half pretrial, and we have a small population, maybe 25 incarcerated women. Our sheriff is an elected official, serves a 6-year term, so is our district attorney. We have appointed judges. In our region, we have 2 district courts, a superior court, 2 drug courts, and Franklin County, you know, like many rural counties, we're a bit economically depressed compared to other areas of very wealthy Massachusetts. In our facility, almost half of everyone has an opioid addiction. That number keeps creeping up every year. In 2014, we started, with Second Chance Act funding, we started a co-occurring mindfulness-based CBT program. Mindfulness at that time was still very controversial. In 2015, you know, like many agencies, we started with our MAT with injectable naltrexone, with Vivitrol. Then in 2016, we started a little bit of a heavier lift, and we offered buprenorphine. And at that time, we more or less arbitrarily decided if you were on a script for 4 weeks prior to being incarcerated, we would continue it. Then by 2018, we did the heavy lift of offering induction right at the beginning of one's booking. So when someone is booked into our facility, they're screened almost immediately by a medical provider. And if we deem them appropriate for an MAT, if they have an opioid use disorder, we can offer them methadone now, and beginning in 2019, we became a fully licensed OTP. So we can offer methadone, buprenorphine, or Vivitrol, depending upon the provider and the patient. And like many jails, people here work in jails. The model for reentry, it's not that complicated. We start working with reentry right at booking. It's assessment driven. We use a risk need responsivity assessment. And then what's our focus? Our focus is on skill development, skill building. We teach them recovery skills, mindfulness-based CBT. In our facility, we love dialectical behavior therapy, DBT and ACT, trauma-informed care, education, vocational training. None of these things are very science fiction here. Skill building, assessments. We offer MAT, of course, post-release case management support. So when someone leaves our facility, they are assigned a case manager that offers them wraparound case management services. And that whole idea is generating a warm handoff. This topic is community linkages, and we're going to explore this the most. We also have a harm reduction approach. We offer naloxone kits, Narcan. Where do we start? So the opioid epidemic, guess what, is not a problem for jails alone. It is a community problem of which jails are just one small piece. But it is a great place to offer an intervention because they're there, and for a public health intervention, it's ideal. They're locked up. So we can offer some interventions. The first thing to do is to identify key stakeholders in your community. Every community will look different. If there's 100 jurisdictions in a room, every one will have different resources and different challenges. It's very helpful to identify stakeholders and then also who are your champions. You met one of ours in Franklin County. It's Dr. Ruth Potee. She's a powerhouse. But there are other people like her. Maybe it's a legislator, maybe it's a sheriff, maybe it's a doctor. It could be anyone. But these people will help move the situation forward. Who are the stakeholders for the opioid crisis? Well, I work in a jail, so our closest partners are, of course, our criminal justice partners, the police, criminal courts, probate family court. Who else? We have primary care and behavioral health, hospitals, opioid treatment programs, community health centers, harm reduction agencies, recovery homes, and then other social service providers, and then the community at large, right? So people who are in recovery themselves, peer recovery centers, social assistance programs, also family members. Many, many people are affected by this opioid crisis. Many people know someone that they love or care about that's been affected, and they want to do something about it themselves. In schools, K through 12, this is an important part of prevention. And also, I hate to say it, there's a lot of confusion about teenagers believing that heroin can be a recreational drug. I want to introduce you to something called the Sequential Intercept model. Has anyone heard of this before? A few people. Okay. So this is a way of mapping out resources in your community. Resources, and then also, maybe more importantly, gaps. And it looks through the whole spectrum of the criminal justice system. It starts off at Intercept 0. This is basically prevention. This is before people get linked and hooked up in the criminal justice system. Then we have, 911, we have law enforcement, we have first responders. What are the resources that are available there? Are they giving out Narcan kits? What are they seeing? Then you have initial detention and court hearings. Like, what resources are available at this juncture of the criminal justice system? And then jails and courts, specialty courts like drug courts or mental health courts, and reentry post-release. And then community corrections like parole and probation, where the rubber hits the road. They're back in the community. What resources are available to them, and what gaps are there? So this can be a facilitated discussion, and it's led by someone who understands the sequential intercept model. And you can have something that looks like this. Okay, so this looks a little complicated, right? But every jurisdiction, the map will look really differently. This is what it looked like after a meeting of our stakeholders in 2016. We got together, we saw what resources we had, we saw what gaps we had, and then we identified collectively, what do we want to do first? What are our priorities? And this is a document that can be generated. This is important for if you're doing community linkage. We remember, it's not just a jail problem, it's a community problem. Everyone needs to be participating. And you can do it not just for opioid use in general. We did sequential intercept mapping, one for the western part of the county, one for the eastern part, and then we did the whole thing again, specifically for pregnant women. So you can do this mapping and resources for very specific or responsive to like a specific population. And we discovered huge gaps of services that were available for opioid-dependent mothers. So not only is it great for developing understanding and clarity about what resources you have and what gaps you have, but these meetings develop relationships and collaborations. I want to introduce to you also another resource developed by the Council of State Governments. So the National Reentry Resource Center is a website which is funded by the Bureau of Justice Assistance. And they released a kind of hub and spoke model for providing reentry support. Now, this is not designed specifically for opioid-dependent people, but guess what? It works for them too. This is designed for how to do comprehensive, collaborative case planning where one agency is more like the lead, and they're sharing information, and they're sharing documents, and they're having team meetings with people from different agencies to collaboratively case manage a shared population. And on this website, you can see examples. I forget I have this button, right? Cool laser. So behavioral health, there have been an example of if behavioral health is the lead, or if it's a community supervision agency like probation or parole, or a correctional agency. So on this site, you can learn more about our program in Franklin County if you decide to go there. We're a demonstration site for the correctional agency. I'll show you what it looks like for community supervision. So you have the lead, case planner, and these are important parties that have been identified as supports for our population. So you can learn more about how this works there. What are problems? We know what the common problems are for recovery, right? We have housing. Housing is a crisis. In rural Franklin County, housing is a very severe crisis. People are dying in the winter from the cold. Employment, we know that people need to often they need to completely change their peer network. Much easier said than done. Family issues, people who are using in their family. Many of our clients don't know what to do with their free time once they're sober. It's very triggering just to be sober and not have something to do. And then navigating complicated systems, right? So if anyone's had to fill out federal financial aid, you know that that's a beast. How do we expect our population to be doing that or sign themselves up for health care? Some of these things are extremely complicated when they're already feeling completely overwhelmed by other things. Our population also, we know, they suffer with mental health issues and trauma. I want to talk about specific challenges related to opioid-dependent clients. And here's one. The elephant in the room is that these medications, these MATs, are only effective if they're adhered to appropriately. And our population has a really hard time with that. So if you have a script for buprenorphine, for Suboxone, the street value is between $25 and $35. So, and maybe you're leaving jail with nothing, right? So why not take a pill and sell a pill from your script that you got for free? Take a pill, sell a pill. Well, the problem with that is it doesn't really work. This is a perfect road to relapse. The medication will only give you the stable experience of not craving if you're adhering to it. So what do we do to support adherence to medication? Well, IDDT case management, integrated dual diagnosis treatment case management. This is basically trauma-informed approach. Drug courts are highly evidenced to be effective. Telehealth does not necessarily mean, having a video screen meeting with your doctor. Telehealth can just mean we send affirming text messages to our clients every day. We check in with them. We proactively check in with them. We don't just wait to hear from them. Contingency management. Contingency management is sort of like incentivizing a behavior that you identify. There's something that's called the fishbowl method. I did not make up that name. It's real, it's evidence-based, and it is called the fishbowl method. So basically you have a fishbowl. It's filled with raffle prizes. And if a client comes to their case management meeting once a week, they get a pull from the raffle. And this is highly evidenced and effective to support client engagement. And then your community, there has to be treatment present. If there's no methadone, if there's a methadone desert, then you're not going to set someone up on methadone. If there's no buprenorphine, then you can't set someone up on buprenorphine if they can't get a script. So ensuring that your community has physicians and providers that have data waivers, that means that they're able to provide buprenorphine, is really important, and that can require community organizing. The last special challenge that I really want to talk about is, unfortunately, it's human trafficking and sexual exploitation. This is a huge problem we discovered. We had no idea. Close to 100% of the women incarcerated in our facility have self-reported being sexually exploited. It's also a huge concern for LGBTQ youth. And the problem is hidden. The people don't want to talk about it, and they don't necessarily even identify that they're being victim, because it is not as though people are in hooded masks going and get in the car. That happens somewhere on TV in the movies, and that's real. That happens to people. But 95% of it is individuals are groomed from their youth. And they're not groomed by creepy people and hooded whatever. They're groomed by professional, local business owners, teachers, lawyers. And they work with, they develop relationships with young people who are often in the system. They might be in DC Department of Children and Families. They might be in youth detention. These are the individuals who are identified and their relationships are groomed. What do? We meet clients where they're at. We can't say, you know, if you're doing sex work because you need to eat, we just can't come down like a ton of bricks. This is bad. We have to meet them where they're at, develop assessments and learn how to talk to them, use motivational interviewing techniques, help clients develop new support networks, easier said than done, right? Psychoeducation on sexual wellness and harm reduction, easily overlooked, but the base knowledge for sexual health is very limited with our population. It could be with yours too. And then peer support. Our clients want to hear from their peers more than they want to hear from me.
Michael White. I work for a opioid treatment program. I'm fortunate enough to work for an opioid treatment program that invests in the communities we serve. We provide all 3 medications. I believe you all have heard enough about the medications. So what's interesting is when I came on board for this company in 2015, it was to set up the collaboration between Maricopa County Drug Court and Maricopa County Jail. And the reason for this is kind of a perfect storm back in that time. So April of 2015, SAMHSA comes out with an announcement that says, if you want funding for year 2016 for your drug court, you will have a process for people to be involved in medication-assisted treatment. We've spent all this money in research, all these other things, so get on board or we won't cut you a check. At that same time, Graves versus Arpaio was a 20-year lawsuit. How many people know about Sheriff Joe Arpaio in here? He's pretty famous. So pink underwear, tent city, all that good stuff. But what happened, Graves versus Arpaio, 20-year lawsuit, came to arbitration around that same time. What it basically said is any care you're allowed to have in the community, you should be afforded to you behind the walls. At that time, the chief medical officer by the name of Jeffrey Alvarez, Dr. Alvarez, said that he would like to start an opioid treatment program. The only models back then was Rikers and a different kind of model in New Mexico. So they became their own independently licensed opioid treatment program. So that jail campus is made of 4 facilities, or 5 facilities now, if you count 4th Avenue. All 5 are independently licensed. They serve somewhere in the neighborhood of 100 people a day. And those types of things. So that's how we got there, right? So I'm trying to coordinate these 2 systems, drug court, jail. We're implementing peer support to attend the drug court staffing, to be able to say, hey, Joe Smith failed a UA, he'll be coming into jail later on today, and those types of things. What happened is I'm sitting in court one day, drug court, and this young lady's celebrated by, at that time, Commissioner White. She says, you're doing fantastic. She gets A-listed, which means you get out of court early, you get 2 gift card draws, all those types of things. And so on her way out, she comes by me, she says, hey, Mike, I got this family court dependency hearing, will you go with me? And I said, absolutely, let's go. So we drive 8 miles away, one court, she's being celebrated. We barely get into the room inside this Department of Child Safety court, and Judge Pineda, if you ever move to Phoenix, vote no on Judge Pineda. And so we get into her court, and she says, I am moving to sever the rights of your child today because you continue to be on medication-assisted treatment. She still does not have her children, right? And so we kind of back researched how we got to that place. And so in looking at that, what we found is we were very segmented in the community. And so you had a DCS system that was kind of working within their silo. You had a drug court team and a probation and jail working in their silos. You had residential. So what we found is that she was connected to a residential program, would have supported her and her child for another year, but a longer term plan of 2 years. She was a combat vet, so she had she was getting services through the VA. All the services that happen when your child is out of home placed and those types of things. So she had a DCS worker, family court, all that. And then she would visit jail once in a while, especially in the first part of her thing, first part of her sentence. And so you can see that none of us were talking together and all of us were working in these silos. So what it caused us to have is an opportunity for then our peer support team to go out and basically hand collect all the resources that were in Maricopa County. And so all the residentials, all the people that did IOP, all the food box places, but that was our first step to just try to get as many people on our team as possible so we would not have a wrong answer. And so that was really our foundational aspect after running into this young lady. So what we did is adopt a collective impact model. So what we do with these teams that serve a large percentage of people together, so 100 people get an MAT at any given time, we have monthly meetings where we get together as a team. Any issues that we've had the last month, we can discuss during that team. Did anybody have staffing issues? Do we need a week off for this provider, and this provider can pick up the slack? But those types of things. So collective impact model. This is just a very fancy picture of everything I just said. But basically, we all have a common agenda, right? Trying to lower recidivism, lower relapse, make our communities safe, make sure our kids in the second grade school desk is next to another kid that's supported at home, and those types of things. The backbone organization, unfortunately, is jail or the community provider. The jail's been taking on a lot of responsibilities, especially in SMI or seriously mentally ill. Now y'all got substance abuse. But I do believe there's help out there through community providers. So one of the things that we were lucky enough, after we kind of developed this model and we started tinkering around with this idea of medication-assisted treatment in Maricopa County Jail, we started basically with pregnant population. Then we rolled it into drug court support. Then it got rolled into anybody currently on a medication-assisted treatment, and now they're doing induction. So it was a 4-phase rollout. But in August, a little after we were kind of doing good with the drug court population, we were about to move in to support people that were currently on their meds. We got the SAMHSA grant called the Padilla grant. And so the whole premise of our undertaking this budgetary responsibility was to get people in criminal justice on MAT and let's see the outcomes. And so these are the referral sites that we worked with people. So Maricopa County Drug Court and Pima County Drug Court, Tucson and Phoenix, we have peer support that go into these staffings every day. They support the docket. Maricopa County, it's about 50 people on that docket on MAT. In Pima County, it fluctuates anywhere from 15 to 20, 25, somewhere in that neighborhood. But again, peer support's there every day, helping the commissioner, helping the judge, real-time information, coordination of care if somebody's struggling, pick up services if somebody's struggling, those types of things. Those are just the things I beat to the slide. Maricopa County Jail, this is 10th City. It is torn down now. It's actually a Mosaic program, which is a 7-week intense substance abuse program that does all kinds of different things, but mindfulness, you name it, they do it. Peer supports go in. They have community providers also go in and give. It's kind of like they can shop, like the offender can shop for the provider they want to be connected to on the way out. So different providers come in on a daily basis, basically from 11 to 1. We come in every Wednesday. We do presentations on harm reduction, how to get in touch with syringe access because it's illegal in Arizona, those types of things. And so we very much take a harm reduction approach and then services across the community. So we also provide in-reach. That's kind of the catchphrase for what we do. So we're having peer support go into the facility, provide education, provide curriculum, provide one-on-ones, resource allocation, continuum of care, those types of things, and work closely with the jail or Department of Corrections. So what's interesting, I just try to show this slide whenever I can because I think even if you're not ready for MAT, you can be ready for something. And so in Maricopa County, about 900 people come into Maricopa County on a monthly basis with opiate use history. 450 of those could be diagnosed with opiate use disorder. Now what's interesting is Maricopa County is now putting some percentage of those that that are high on the COWS score. So they're putting about, in this case, July snapshot, 338 doses of naloxone in the property bin. So when somebody's getting released, they're putting on their street clothes, they're putting naloxone in their pocket. They also have a harm reduction card for safe syringes if they unfortunately go back to using. So that's one of the things also Maricopa County's doing. We've had large amounts of feedback coming back of it helping save lives. So Alhambra is the intake center, so you all know when you go to DOC, you go through an intake center, you do an assessment, you get placed in a facility, those types of things. So some of our population was involved in Alhambra and then went to Tucson Prison Complex. Again, peer support goes in there and provides a curriculum education type group. We'll get into that here in a second. Perryville Prison, we support pregnant population. We have a heavy focus on pregnant population. So in Maricopa County, at any given time, I have about 20 pregnant patients. In Perryville Prison, I have 10 to 20. It's just near and dear to my heart, especially with the combat vet. And basically, our Department of Child Safety at times hasn't caught up with the rest of the country, and it's very punitive to moms struggling. So they just need a little bit of extra love. So we definitely focus really hard on their attachment to community resources upon release and OBGYNs, resources, whether it's a breast pump or whatever, you name it, we'll get it. So these are interesting. This is through the Department of Corrections. What it is a second chance center. So they have two, Tucson, Phoenix. And basically what it is if you get released from DOC and let's say you relapse or you start struggling, your parole officer can give a recommendation to go through a 30, 60, or 90-day program before being sent back to prison. So you go into this facility and they have services upon services. So they got art therapies, they got CBT, they got DBT, they got Seek and Safety, they got all these services. This warden named Patty Barnhart put the model together and is very supportive in kind of anything you would need in there. But we provide the MAT and the peer support education piece of this program. So basically for the MAT perspective, an offender can come in that night. The next day they would be inducted on a medication, whichever medication. If it's naltrexone, they got to go withdraw first and then jump on it. But any of the other two medications they can basically get on that day. And then every Wednesday we do telehealth, and then we would do medication adjustments if needed during that time. So once they bring in the offender for the first face-to-face induction, they never have to come back to our clinic while they're incarcerated. So you do the telehealth follow-up, and any medication adjustments our nurse delivers later on that day. So then she or he goes to that facility and throws in the medication into lock boxes, which are also behind 2 lock boxes. And so then they just place them patient A, patient B, patient C, that type of thing. So basically the staff there doesn't have to touch anything. Our nurses put it in. Staff just comes and unlocks it. The person takes their daily dose, goes away. Every Wednesday we do med adjustments, whatever. During that time, our peer support are coming in 5 days a week. They're doing topic classes. We do 2 on Thursday, then just 1 on every other day. And we cover evidence-based topics and try to help people work through that. So this is demonstrating 30, 60, or 90-day. By the time these people come out into the community, they have a really strong relationship with our peer support, and they're more likely to cross that threshold of coming into treatment, which can be riddled with high anxiety coming into a treatment facility. So Matt Padilla, those were the referral sites. We would see them as very high-risk folks. You know, throw away the key, hold them accountable, do those types of things. We're looking at 252 clients right here. 27 to 73% male-female breakdown. Average age 32.7. Post-secondary education, 34%, so a pretty well-educated population coming out. Overwhelmingly white. So what we saw, this was third-party collected. If you've ever done a GIPRA, it came through GIPRA, but then we had a third-party data collection agency called Wellington collect this stuff on our behalf. 33% reduction in arrests, 38% reduction in drug arrests. So I'll remind you, people that were not on MAT, now involved in the criminal justice, on MAT, their main workforce or labor force supporting them, peer support. 38% reduction in drug arrests, 57% reduction in crimes committed, a 57% reduction in nights spent in jail, which should be an asterisk, because if you look at the drug court population, any accountability measure, you miss a PO, you miss an IOP meeting, it's 24 hours in jail. So if you took that population out, it would probably be higher. We had a GIPRA follow-up rate of 75-25. That's really good if you're not aware. To be able to follow up with this population being as transient as it is 6 months later. It's because of all those relationships we had with that collective impact model that we were able to track those folks down and get that 6-month follow-up. This can be scary for criminal justice populations because you look at it and what we're demonstrating is people lowering their amount of use or lowering the days used. But when you look at this, you say, well, 33% are still using. Yeah, that's true. But we did see a 44% offset. And with benzodiazepine, we saw, you know, a 18% offset and those types of things. So I'm a harm reduction person. So when I look at this, I see great things. If I was criminal justice and I was in the business of holding people accountable, I might look at it a little different. I don't need to do that, so I won't. One of the best things, 28% reduction in unemployment and an 85% increase in employment. I could probably redo this study or this project for the next 10 years. I don't know if I'd ever have 85% employment rates again, but that's what it was. Very good. 43% increase in permanent housing. So what we then did is, you know, this was kind of up and running. 2016, we knew we kind of had a good thing. We start getting some national attention of the model. Go around, people were struggling with it, so we were helping them. So Cass County, Ward County. At this time, my company, the company I work for, works in 9 states. I support facilities in 8 of them. It's somewhere in the neighborhood right now of 24 facilities with 4 more coming on in the next 2 months because of federal prisons. I'll talk to you about that in a second. But these are some of the facilities I support. A young lady earlier today stood up for North Dakota and said she was doing Hep C treatment. They're phenomenal. Like DOCR, North Dakota is just, they're way above the rest of us on the way to think. And it's all because of Dr. Hagen and Lisa Peterson, their clinical director. They're just doing phenomenal stuff out there. We support Alaska, so it's a 45-mile one-way drive for our nurses. We do not do peer support in that facility. We just haven't got there yet. And about to start with Milwaukee and Wisconsin DOC because they share the same third-party healthcare provider, so it's pretty easy. They got a BJA grant, so they'll be looking at that. So a lot of these services happen pro bono because as a provider, I can't reimburse going in, right? You can't bill Medicaid for services provided to people behind the walls. Grants can help. But at the end of the day, it should not be hard to get a community provider inside your facility to help. It shouldn't be. They're picking up referrals. They're picking people up in treatment. Like you can play that devil's advocate there and try to get people entertained in the idea of supporting your folks or getting some support from outside of the walls. So the First Step Act just recently placed. My phone's been kind of going crazy in December because federal prison, the third-party healthcare providers supporting federal prisons, needed something in place, I think January 1st, to be in compliance, to be able to demonstrate that their folks would have access to MAT. So for 5 years of doing this, federal government didn't say a blip. You had NCCHC kind of saying stuff. You had ACA, American Corrections Association, kind of planting some seeds. And so you had those types of things. But with the federal government coming out and saying these things, I think it's only a matter of time as, forget the lawsuits, just founding to be accredited or to do these other things. I just think it's going to become mandatory here in a second. Second meaning a long cultural shift. So some of the challenges I've experienced is employee culture. So in my world, you have the third-party healthcare provider, you have the sheriff, and then you have the line staff, right? And none of them really are aligned at the same time at any given time, especially when you're talking about medication-assisted treatment. Either one of them could be for or against. It's just that, that relationship. Pharmaceutical companies, certain pharmaceutical companies can come in, have conversations with corrections, and kind of taint the conversation of not understanding MAT to its full extent or overselling the idea and these types of things. So oftentimes I would get called in a year or two after they've been running a project to try to help out change the direction of that project, if you will. Third-party healthcare providers, they can be entertaining, or they can just not do their work, which is something we've come across sometimes. Concerns over diversion, it's real. Buprenorphine tablets are cheaper than the film, but the film's going to be diverted less than the pills. It's those types of things, separate med lines. I mean, it does come with difficulties, but there are ways to minimize your level of diversion. Facility and staff resources, when I talk about Minot, North Dakota, they might have a nurse 3 hours a week because they're moonlighting from the hospital. So they just might not have the resources to be able to do a project like this. And then peer supports. So my personal philosophy is the longer your rap sheet, the better employee you're going to make me. That is not your same definition. I like people having the most lived experience that they possibly can. The problem is then I'm trying to send them into your facility because I think they're going to be the best possible person to get in front of your folks. So that can become a struggle just from that point, and we get people denied quite a bit, and then we go through a process of asking please, please, and then you try to bribe somebody, but not really bribe them. But those types of things.
Technical assistance is available to support the evidence-based prevention, treatment, and recovery of opioid use disorder. To request technical assistance, visit opioidresponsenetwork.org.